I talked to your transplant surgeon today. You do just as many transplants as we do, so I don't know that I'm going to be teaching you anything new, but I might give you a different approach as to how I do it or how we do it in our institution. So with that, we'll go on. So I have no disclosures, okay? And here are our objectives. We're going to look at the vasculature in the kidney, the liver, and a very little bit in the pancreas. We'll talk about abnormal Doppler parameters as predictors of transplant complications. And then also, because ultrasound is first, but it isn't always last. So we do need to know when to call out the CT or the MR for our additional imaging. So this is just to give you a perspective. You can see that by far, the kidney is the greatest number of patients who are living with a functioning graft. This is from the OPTN annual report. They haven't really updated this since 2008, so that's the only color one I've got for you. But you can see that the number of kidneys in the green is about 3 times the number of livers, and then heart and lung are low. They didn't even list pancreas. This is the latest I could get for you, but you can see again, kidney is about 3 times as many living patients transplanted as livers, and then heart and lung and pancreas are much smaller. And in addition, when you look at the number of recipients alive and well, and this is, you can see that the line is just going up diagonally, and you can imagine that at 2012, 2013, that number is going to continue to grow. Because these patients do well with their allografts, the kidney transplants can live for 15, 20, even 30 years. The livers, not quite so long, but not bad at all. So again, number of patients with liver transplants alive, well above 60,000, I would imagine at this point. So with that, we're going to go to the most popular transplant, which is the renal transplant. And just a reminder of how it's hooked up. It's a little simpler than the liver. It just has 3 hookups, inflowing artery, outflowing vein, and then outflow for the urine into the bladder. Typically situated in the right lower quadrant, but as you'll see with pancreas, it can be done in the left lower quadrant, or if you have people with a right transplant that's failed, then the next one they get put on the left. So the things that I'm going to be looking for initially is basically in the acute situation, first couple of weeks, I want to be looking at, or actually first few days, is the artery intact and is the vein intact? And that's going to dictate some of our imaging. Later on, we're going to be looking at ATN, acute tubular necrosis, rejection, some extrinsic compression, and the other things like AV fistulas and pseudoaneurysms. And lastly, the chronic problems, which are renal artery stenosis and rejection. So just a time frame. So in the first 24 hours post-transplant, you really need to know, is there arterial inflow and outflow, and is it good? So to begin with, you always start with a grayscale with ultrasound. So you want to get a good long axis and short axis, upper, mid, and lower pole. You want to look for any peri-transplant fluid collections and get an idea of the size. Look for any dilated collecting systems. This one, of course, is normal, so the collecting system is not dilated. And in Doppler, we're going to be looking at the main renal artery, the anastomosis, and also the feeding iliac artery. And that's to get an idea of what is the inflowing velocity of the blood in that iliac artery. If that's very high, then a high velocity in the main renal artery won't be very alarming. If that's low and the main renal artery velocity is high, then that signifies that we have a mismatch or a stenosis. We want to demonstrate that there's a patent main renal vein and also check the iliac vein as well. So I found it very useful to have sort of the iliac vein and the iliac artery sort of as comparisons for what's going on in the allograft. So one step vessel removed. And in the parenchyma, we're going to be sampling throughout the transplant. We want to look in the upper and mid and lower pole, partly because I find that if you say to the sonographer, oh, just take a picture with color, and you don't get the resistive indices, you're not really going to know how the kidney transplant is being perfused. You're going to be looking for good diastolic flow. The kidney is sort of like the brain. It likes to be perfused continuously, so it's going to want to be perfused throughout the cardiac cycle. And a normal resistive index, as you can see there, resistive index definition there is less than 0.7. As I said, I have the sonographer's sample in upper, mid, and lower because I don't want them to miss anything, and it's good practice for them to be getting it all the time. I don't want them to forget. Okay, and so if you don't have something as part of your protocol, it's easily forgotten. Some people will add it, some people might miss it. Okay, so as I said, the most acute thing that you can see in a renal transplant is basically a major vascular problem with the artery or the vein. And so renal artery thrombosis, fortunately, is relatively rare, but it is certainly a significant problem. And you pick it up immediately post-operative. Patient will be anuric, and it's treated either with a thrombectomy if you catch it in time, or transplant reposition. And this is at a sort of a typical waveform here. This is just basically no diastolic flow, whatever, and sort of a mirror image, almost like a wall thump. That you can see here. You can see that the reason to sample the iliac artery is you can see that there is a normal waveform in the iliac, as you'd expect. I'm losing my arrow here. So normal iliac waveform, very abnormal renal artery waveform. Okay, this patient had renal artery stenosis, and they took her native kidney and they stuck it down in the right lower quadrant. So it's functioning like a transplant. So she's an auto transplant, and she had no urine output in the OR, and so they asked for intraoperative ultrasound. Do you do any of that here or not? Do you ever get asked to go? So every once in a while. Okay, so anyways, well, here you are, and you could see that we saw pretty easily detectable color flow in the kidney when you're looking at it actually through all the skin and sub-Q. Here we are right on top of it, very low color scale, and there is nothing in it. You can see a little bit of color activity deep, but there's nothing in the kidney itself. So that's very abnormal. So that prompted the surgeons to go back in, and she actually did have a thrombosis. They disconnected the transplant basically at the anastomosis. They went through and then they reverse flushed it to get out all the clots, and they sewed it back in. And post-op, you can see easily she looks quite normal, and she's got good flow throughout the kidney. This is a 12-year-old, and he had a living-related donor transplant. And what do you think about these images? So we've got lower pole, mid, and upper pole. We've got normal resistive indices. Anybody see anything abnormal here? Well, these color boxes are sort of narrow, okay? But they do go pretty far back. And what's going on in the back here? We know that color is sort of limited based on depth, right? So the sonographer got me another picture, and here it is again. You can see tremendous flow in the front of the kidney, not much in the back. So is it an artifact because we just don't have enough penetration? Should we do something with our color, or what should we do? Well, one nice thing about ultrasound is you can move to a different position. So I told the sonographer, don't image from the front side here, go 90 degrees and show me something from the side. And so she did. And when she did that, you can see here's this whole half of the kidney that's perfused, this whole half is not. So not an artifact, actually a whole half of the kidney is not perfused. So something else to keep in mind. This patient actually had multiple anastomoses, and they were small, and so some of them just didn't work. But enough worked, and they left him alone. Okay. How about this patient? So we talked about the resistive index. We should be seeing flow throughout diastole. What's happening in diastole here? Flow is reversed, right? And we're seeing it up in the parenchyma. We see it in the main renal artery. And here's the iliac artery, which is still, it's perfused, it's normal, it's not a great picture. And the iliac vein we see is patent. What's missing from this picture?
Renal vein.
Renal vein, absolutely. So this indicates what? Renal vein thrombosis, basically, until proven otherwise. And so these patients present with acute swelling, non-functioning graft. It's usually days 3 to 8, but I've seen it certainly earlier. I'm sure you guys have as well. And the way you salvage this kidney is, again, figure it out early, send them back to the OR, they get a thrombectomy. So diagnostic criteria, absolutely absolute. Venous flow, sometimes you'll see a clot in the vein and this reverse diastolic flow in the intrarenal arteries. But remember, you can see that also in some other things like acute rejection or even compression syndrome. Okay? So it's a sign of renal vein thrombosis until proven otherwise. Okay? All right, here's just an example. This patient was ultrasounded just for pre-biopsy, and we happened to pick this up. So here's a clot in here. It's a partial clot, and the patient got no therapy, and I have images of this patient 7 years later. How about this? Renal vein thrombosis. Got the reverse flow in diastole, right? Patient went to the OR, but there was no clot in the renal vein. Instead, this was basically a compressed transplant. This is renal vein compression by basically a compartment syndrome. And so it looks the same, and the outcome is the same, right? You're going to take the patient to the OR anyways. So transplant compartment syndrome is thought to be related to ischemic injury and then swelling from reperfusion. And so they don't, in other words, we don't really know why it happens. The Doppler findings mimic a renal vein thrombosis, but basically you take it back to surgery and move it, take it out and relieve the pressure, and that preserves the function. Okay. Okay? So this is actually a pretty reasonable article from Transplantation, if you want to take a look. So here again, this patient, main renal vein area, there's nothing in the main renal vein. We can see the reverse flow here, but this was also a patient with a compartment syndrome and not a renal vein thrombosis. Okay? And after going back, you can see that it's now normal. How about this patient? Day 0. This is a terrible waveform, right? So there's absolutely no systolic upstroke here at all. And here in the main renal artery in the hilum, velocity is pretty low. There is some flow, okay? And when we looked further, this patient has this very strange position of the renal artery. So this main renal artery also has almost sort of a tardus parvus waveform. It's got sort of a slow upstroke, has a lot of diastolic flow. Iliac artery was normal. So this patient's waveforms in the kidney, that's not adequate. So he went back as well. And this also was compartment syndrome. So you can see here after patient, they cleaned out the kink in the renal artery. And here is the waveform here. And again, now in the mid-kidney, the main renal artery looks a lot better, better resistive index, better velocities. So I know you guys had one just recently that you showed me today. And so I think almost any abnormal waveform or poor color flow, if you're seeing it in the parenchyma, you should be considering whether it's compartment syndrome, because you should be able to see flow in these kidneys quite well. Okay, let's get on to the next cause of a high resistive index. What's the cause here, you guys? So this is very, very high, poor diastolic flow here. And this is the kidney here. This is the kidney here. Here's the kidney here, and we're measuring something here. So what are we looking at here that sort of looks like kidney-ish, but it really doesn't have any pyramids and doesn't have a sinus? Yeah, it's a big subcapsular hematoma. Here's another image. Here's the flow in the kidney, and this thing that's sitting beneath it is a huge, huge hematoma. You can see it's high resistance in the artery. There's still flow in the vein, and 4 days later, when it got better, you can see that the waveforms return towards normal. So elevated resistive index, which is basically absent diastolic flow or very little diastolic flow, we can see it from a number of things. We just saw it from extrinsic pressure. You can see it from the obstruction of the renal vein. You can also see it just from graft edema. You can even cause it if you push too hard on the transplant. So it's not a specific thing. You can see low flow. We just saw that also with ischemia and also with AV shunting. So this was another compressive hematoma. They can be very difficult to detect unless you've got the color on, because often the hematoma is isoechoic to the transplant. Okay. All right, so here's a patient, day 0 post-op transplant. Is this renal vein thrombosis? So waveform looks like it could be, right? Very high resistance waveform. But here's the main renal vein. So now your diagnosis is not going back to the OR, not a compartment syndrome, because there's really pretty good perfusion in the parenchyma, so ATN. So this is a common complication. Over 30% of patients, a number will need dialysis, and it's related to the warm ischemia time, so cadaveric donors are more prone than the live allografts. And recovery time, 1 to 2 weeks, but I've seen it take longer too. So that's one cause of a high resistance in the transplant. Other causes below, drug toxicity and as well as rejection, okay? So rejection I broke it into 3 parts. And I'm just going to show you. Hyperacute is actually very uncommon because they do much better HLA matching now than used to be done in the prior times. Acute, very common, still up to 40% of patients. And there are a couple of types, cellular and humeral. The humeral is more of a vascular type and a more fibrotic type. And then chronic basically is non-reversible. So this is hyperacute rejection, and this patient, you can see very, very, very poor perfusion of the kidney, reverse diastolic flow. She does have a renal vein, so you might call this ATN, but this happened so fast within a few hours of transplant that it was too soon for ATN. So she went back to the OR, and actually it was removed at 4 days. It just never functioned. Acute rejection, basically the allograft, if you can see a change, it will swell. You'll lose the sinus, you lose the corticomedullary differentiation. This patient has a very bizarre looking kidney and very thickened collecting system, submucosa. And so you need to think about a biopsy because you need to look at whether it's this type of the cellular or humeral. And this is basically a swollen kidney with multiple small hemorrhages. It responds fairly well. The vascular portion, one is more difficult to reverse, and it gives you basically ischemia and infarcts. So, and chronic rejection, you'll see this much later, but this is a very, very end-stage kidney. Sometimes they'll be very small and shrunken. This one isn't so small, but it certainly has calcifications, and you can see them here actually in the path specimen as well. So they have lots of chronic calcifications, infarcts. Okay. So can we predict function? I'm bringing this to you because this is the only article that I've seen that's trying, and this is from Jonathan Rubens' group at Michigan. They did a retrospective study, and basically they tried to measure the velocity in those intraparenchymal arteries. I think that's pretty hard because it's very difficult to get a long enough segment of that artery to do a good angle-corrected velocity. But they tried, and they are very good labs, so I believe that they did a good job. And they found a lower peak systolic velocity in the patients who had the glomerular edema without fibrosis. They found late rejection has a lower peak systolic velocity. So the vascular form had a velocity of 23 centimeters per second versus 39 centimeters per second in the patients with the earlier or glomerular edema. So whether that's helpful or not, I don't know. I don't think it's going to replace the biopsy, okay? Because I think it's going to be hard for us to reproduce in our labs, and I don't know that it's specific enough to prevent a biopsy. So let's talk a little bit about biopsy. We want to look at patients who have graft failure, elevated creatinines, sometimes, and sometimes elevated drug levels as well. And so that's why I'm saying to monitor therapy. Sometimes you'll take somebody off their drugs and you want to see if they're rejecting, or you want to see what their status is before you remove their steroids. So I'm sure you guys do all these percutaneous. You don't do them? Nephrology does them? Does. Okay, you're in the same boat we are. So are you guiding for them? The sonographer is guiding? Okay. All right, so anyways, 18 gauge. The goal is to get the cortex, okay? So you can go from the long axis, which is the guide, here's the guide here, same as you do for any other guided biopsy, and you want to get this bit here. You don't want to be in the pyramids, you don't want to be in the medulla because it doesn't have any useful tissue for you. And also because the closer you get to the hilum, the closer you are to bleeding, right? So this one is a good guide, this one's good, and that's the idea, is to obtain only cortex. This one, too close to medulla, too deep, and so this is the appropriate place to be if you're going to go across the lower pole like that. So, and notice that your echoes will stay after the biopsy, so we can see where they went and what they did. You can also put the kidney transverse, and that might be a little easier to sort of skim the cortex going this way as well. It doesn't matter as long as you get cortex. So post-complications, as with any biopsy, hematomas, AV fistulas, pseudoaneurysms. So always plan with color. This patient, this is from Dean Nakamoto at Case, and you can see here that there's this very large vessel. Here's the lower pole of the kidney, and if you aren't careful, you'll go through this vessel here. You want to make sure you are aware of all the vessels in between you and the transplant. All right, so here is a young guy, 4 days after transplant. He has a delayed graft function, so they requested a biopsy. So the usual place to biopsy would be right here, lower pole anteriorly. It's very close, right? You just go right in there. So should we do that? No, why not? There's no blood flow here. Okay, so what's wrong here? Infarct. You don't see it without the color. You've got to turn on the color. It's very embarrassing. I have some pictures that I'm not showing to you, but very embarrassing because I have biopsied a transplant like this in the lower pole and gotten back dead kidney. And then you go and you turn on the color and you go, oh my God. And then you have to do a repeat biopsy. So don't do that. So avoid this, and which they did, and they chose a place in the mid-kidney. And you can see there's plenty of flow in there as well. And they biopsy the mid-kidney. Good biopsy? No, went a little bit too deep. Okay, so immediately after the biopsy, there is a new artery that's appeared that's going all the way to the surface. And in addition, what's this, residents? You guys all know this now, right? This is an arteriovenous fistula right here. You can see the artery, and then this is the arterialized vein, high velocity flow below. So, very common. about 10% after a biopsy. They can present with hematuria, but usually they're asymptomatic, and they will resolve spontaneously. You look for the focal aliasing, as you see here, and the high arterial velocity, low resistance because the diastolic flow is just running into that vein, and the arterialization of the vein. That's the outflow. So here's a patient, had a biopsy, didn't see anything initially, but 2 days later, lo and behold. That looks sort of scary, right? You see it just takes over the whole image. Arterial flow here, venous flow below, but it went away in 4 months. Went away probably a lot sooner. We didn't scan him again until 4 months. Okay. So arterial bleeds, do you worry about them following a biopsy? You do. What do you do about them? Mostly you watch them. So this one was very scary. It was pulsing and going right into the area, and it had a lot of nice spectral waveform. This is also from the Cleveland group at Case Western, and they just watched this and required no transfusion, no intervention. So mostly we just watch them and we push on them and try to and hope that the compression will help. Okay. Sometimes it doesn't, and sometimes you get a hematoma. So this patient, this is pre-biopsy, this is immediate post-biopsy, didn't see anything, but 2 days later there was quite a good-sized collection that had appeared. And so they can have a slow ooze as well. You may not see it immediately. What about pseudoaneurysms? Very uncommon. This is from Dr. Hamper at Hopkins. Their appearance and diagnosis is basically the same as a pseudoaneurysm. Anywhere, inflow, outflow, sort of a yin-yang appearance, and the same thing below on the spectral tracing. And again, manage them conservatively if possible. If they're large enough, then you may need to embolize them. Okay. What about stenosis? Do you guys have many cases of this that you know of? I thought it had gone away in my institution. I don't have many cases, and I was wondering why. I thought maybe my surgeons got really good. But this is actually from the national transplant data. There is a fair percentage of them. They're usually at the anastomosis from surgical difficulties, if you will. They'll present either as refractory hypertension or renal impairment, and it can be from immediate time, like a dissection or something in the artery at surgery, up to 2 to 3 years or even more post-transplant. We screen with ultrasound, and so if we have a suspicion, then as a screening exam, your duty is to call something if you think it could be there, and then you confirm with MRA or CTA or angiography. Okay, so how do we make the diagnosis? Well, in the native kidney, for 70% stenosis, we use a peak systolic velocity of 200 centimeters per second. In the transplant kidney, and this is a 50% stenosis we're looking for in these, you can see there's a bunch of criteria, which means that people don't agree. This is from my institution, and basically, in a screening population, Patel says you should use a much higher number than you should in a symptomatic population. And we actually thought even higher, even with symptomatic patients. What about some of the secondary criteria for renal artery stenosis? So renal aortic ratio, again, native kidneys, greater than 3.5, 70% stenosis. We don't really have a ratio in the transplant kidney. So there's one article here from De Moray, and he's from Brazil, I think, that uses almost a 2-to-1 ratio, and he had symptomatic patients. He found 12 that were positive, but he was sensitive but not specific. Okay, so the question is, which patients do you want to send on for a contrast exam? And I'll go into this a little bit more later. The intrarenal criteria, that's the downstream waveform, that's the tardus parvus in the kidney, not reliable as well. We didn't find that this 0.08 was very useful, okay? So what I do is I look at the ratio. So I don't know how you guys are reading them out, but I'll show you why. So this patient, for example, resistive index is fine. Velocity in the anastomosis, 280. Okay, by most people's criteria, that's a stenosis, right? Look at the grayscale. It's perfectly wide open. There's nothing wrong there, okay? Velocity 300 on the grayscale with pretty good angle correction, okay? So the renal velocity is high. I look at the inflow velocity in the iliac. Iliac artery is 144. Ratio is about 2-to-1. I think that's clinically insignificant. So, and more than that, the patient is not necessarily hypertensive or has an elevated creatinine. So the technique is really important. As a vessel goes around a curve, it speeds up, okay? So we're going from an iliac artery here, and then we're going to go tight around almost 180-degree turn to get to the anastomosis. So you can see here, almost 500. Iliac artery, 153. Well, that would be a 3-to-1 ratio, right? But when you get a better technique and you really move around and get vertically onto that anastomosis, velocity is down at 224. So technique's really important as well. Again, another patient, 428, completely normal looking here, iliac artery, 121. So here coming in, 2-to-1 ratio as it's coming around the curve, accelerating around the curve, gets up to 400. So be careful where you're measuring as well. So if the peak systolic velocity doesn't work, what about using intrarenal waveforms? Well, again, I have lots of anecdotal cases here, but it really doesn't work for us either. This looks like a tardus parvus, right? But the velocities were fine, patient was fine, no intervention, and 7 months later, it's completely normal. So I'm sure you find this as well. What about timing? Well, as it turns out, early on, as you'd expect, there's some edema at the anastomosis. So if you sample in the early few months, the velocities will be elevated, and they usually decrease over time. So this is, again, another transplant article. So here's another patient. This is really tight looking, right? Aliasing here, very, very high velocity, 380. Iliac is 150, so it's at least 2-to-1, maybe a little bit more. Almost a tardus parvus waveform here. And however, 2 years later, velocity is lower, medical management. So our guys aren't treating them, okay? What about the ones that really are? So this patient, this is an early case, you can see by the old ultrasound. It's at least a 2-to-1 ratio here, suspected stenosis. So this patient went to MRA, and it was a 50% narrowing here, but sort of goes around the corner too, and nothing was done, okay? This patient, however, has a very, very high ratio, probably 4 or 5-to-1, right? And a high velocity and a very tight stenosis. And this was angioplastied, okay? So does it matter? I've only shown you one case so far where we've treated it. The National Transplant Database had about an 8% incidence of renal artery stenosis. 70% of those patients had angioplasty. That means a large percent were left alone. There was no difference in the blood pressure or the renal function between the ones who were plastied and the ones who were treated medically. Okay? They did say that it was associated with an increased risk of graft loss. And a similar study, this is from a larger group, single center study, 13 years, and this is from the group in Scotland, I think, Baxter. Is it Ireland or Scotland? Anyways, a large transplant group, and of the patients with renal artery stenosis, 43 patients out of 1187, again, small number, right? And they divided into angioplasty and conservative therapy and saw no difference at all between the two. So it may be that medical management is the way to go. So I don't stress so much about renal artery stenosis. And anyways, here's another patient again. But I do stress about patients who have tardus parvus waveforms. So here it is in the lower pole. But when I also see it in the main renal artery. And why is that? What about the iliac artery? Also abnormal, right? The iliac should be high upstroke and should have some reversal in diastole. So this patient has actually an inflow problem up in the iliac artery. So this patient may have continued problems with their transplant, okay? If they're functioning okay, you're not going to do anything. But if they aren't, then they should treat the iliac stenosis, okay?
Deborah,
yeah?
when do you decide to send them for angiography? At what point do you say?
We usually go to MRA first. And because angiography is invasive, there's a risk of dissection, at least theoretically, and you'd rather not give them the contrast if you don't have to. So most of these people their creatinines don't go down to perfect. There's only one kidney, and so we try to keep them off of contrast, IV contrast from CT if we can. So this is what I think. This is my opinion. So I think the ratio is more useful in my experience than an absolute number because I have so many of these twisty-turny anastomoses. And if a 2-to-1 ratio is a 50% lesion, is that really a significant stenosis? Should that be treated? Especially since the national data is that we shouldn't be treating these anyways. And if you're going to use peak systolic velocity criteria, then just use some restraint. If you have a symptomatic population, you might want to use 250. For an asymptomatic population, I would go up to 300 at least and maybe even 350. Okay? And the intrarenal waveforms are not really reliable. Okay? So, yeah.
Do you screen your iliac arteries pre-transplant?
We do in terms of, not with ultrasound, but many of these patients, if they have significant arterial disease, they get a non-contrast CT and they look at the amount of calcification if they're worried that the patient's a vascular path. But it's not in everybody. So the surgeons are selecting. So our pre-transplant imaging for the recipient is very little. It's mostly for donors. So. Okay, livers. How are they different from the kidney? Well, for one thing, they have more hookups. And so this is the sort of the basic where you actually set in the IVC into the part coming up from the legs and the part that's going to go to the heart. Okay, so one hepatic artery, two in the IVC because you're sort of setting the transplant in there, and one at the portal vein. And then of course there's the bile duct as well. That's the liquid outflow. To simplify that, our surgeons are doing this, which is a piggyback anastomosis. So you just leave this part oversewn. Don't have to hook that back into the native cava. Just hook up at this superior end. Okay. And then in addition, I have one more slide here just to remind me to tell you that there is a living donor transplant. We stopped doing them for a while. We may be starting again. And in that, you're basically going to take the right lobe of the liver to the right of the middle hepatic vein and sew that in. So if you're going to study those patients, you have less vessels to look at. Okay. So the imaging protocol, grayscale, of course, first, liver and spleen, and the surrounding parenchyma, if you will, or perihepatic spaces, and then color and spectral Doppler of all the arteries, the veins, splenic vein, and the IVC. And I said with a living donor, you would only have to do the main and right hepatic artery, you'd only have to do the right portal vein, and you'd only have to do the right hepatic vein. Okay. So major complication, as you all know, is the hepatic artery. And either thrombosis or stenosis. And less common are the venous side. Okay, it is the leading cause of graft failure, hepatic artery stenosis or thrombosis, 13% of patients, and we still see this, unfortunately, more often than we would like. So the patients usually have poor perfusion, poor oxygenation of the bile ducts. That leads to necrosis, abscess formation, and eventually they lose the allograft. You can diagnose this in about 10% of asymptomatic patients with early screening. Okay, and the treatment is either arterial revision or retransplant. So this is a disastrous complication. So you can see here is a patient with a lot of diastolic flow, basically a low resistive index in the right hepatic artery. That's a sign of an ischemic artery, right, a downstream ischemia. And you can see here is a lot of echogenic material sitting along the ducts. You can see it here in CT as well. The ducts are dilated and filled with debris. And you can see here on the PTC as well. So these are necrotic bile ducts. Okay. So the diagnosis hasn't really changed much since Chip Dodd's article. It was actually back in the early 90s, late 80s, I think, but he looked at it again back in 1994 and it hasn't changed much. So we look at this resistive index or the acceleration time. And in my lab, basically, we look at the acceleration time visually. So this would be delayed, right? It's a tardus parvus. It's a slow and slanted upstroke. It's not a brisk straight up. And the resistive index we measure. So this one is 0.33. False positives can come from, if you can't see the hepatic arteries, you can think it's gone, or reperfusion injury and with some shunting. But that should give you a normal acceleration time, a good brisk upstroke. And you can also have rapid collaterals formed, especially in pediatric patients. So that can give you a false negative, if you will, for hepatic artery thrombosis. So just some examples. Here is a normal hepatic artery, and then this is a very bad sign when the sonographer goes attempt. You know that's bad. So right hepatic artery attempt, there's nothing there. She's just getting a little bit of stuff flashing in from the portal vein. Main hepatic artery, nothing is there, just a little wall thump. So that's obvious. You were able to see it. It went from being present to being gone. There's no question there that patient has hepatic artery thrombosis. What about this patient? Low resistance in the right hepatic artery. Main hepatic artery looks normal. Okay. So is this hepatic artery stenosis? The main still looks okay. Is it a hepatic artery thrombosis? And how can you decide? And the answer is you can't decide. By ultrasound, you need an angiogram. Here's the angiogram, and this is complete occlusion of the main hepatic artery. Okay. All you're seeing here is collateral flow. Okay. And unfortunately, this patient went on to have biliary necrosis as well. This patient, post-op day 0, is this hepatic artery stenosis or thrombosis? Well, we said the resistive index here is pretty low, right? Lots of diastolic flow. But look at the velocity here. It's really quite high and good upstroke. So what you're going to do here is restudy in a day, and basically this is intraparenchymal shunting. This is a reperfusion effect, and it goes away as the liver sort of calibrates to its new blood flow. So we actually looked at some indicators, what was worthwhile to do in terms of indicators for hepatic artery stenosis, thrombosis. And so we wanted to look at the spectral Doppler and how often does it look normal. And it looks normal about 40% of the time. And this pattern, this RI of 1, is also about 1/3 of the time. Okay? The other third is divided here with a resistive index less than 0.5 and absent hepatic artery in 12%. So this is the low RI, here is the absent HA. These are the patterns we're going to look at. So you can see that in the early post-op period, first 10 days, you actually have a lot of waveforms that are not normal. So what do they mean? So one article came out actually in 2003 and has been revised a little bit to ask if this waveform predicts thrombosis. And I was just talking to your transplant surgeon, Dr. Wall, today, and he is in agreement with us. The answer is no, it doesn't. It can go from hepatic artery to no hepatic artery, as this patient did. But most of the time, if your RI is 1, it's about the same predictive value as a normal hepatic waveform. So most of these actually will return to normal, and they do not go on to hepatic artery thrombosis. The patients who actually had hepatic artery thrombosis in our series of 5,000, out of them, you can see that about 1/3 we couldn't see the hepatic artery at all, and 8% had a low RI. Okay. So absent diastolic flow, this high resistance waveform usually returns to normal, and there is no increased incidence of hepatic artery thrombosis. And that's actually been supported in the rest of the literature as well. Okay. So what do we do when we can't see the hepatic arteries? I've said that's the biggest predictor. So we will rescan these patients in less than 24 hours. We have 24/7 ultrasound sonographer coverage, so they're there in the building, and the more experienced ones are actually on in the evening and at night. So they will rescan, and most of the patients actually, we will find hepatic arteries that come back. So about a 77% incidence if we can't find it in the first 24 hours, but most of the time we'll see these come back. If it's persistent, more than 24 hours, one or more hepatic artery has about a 70% incidence of hepatic artery thrombosis. Okay? So what can you do to improve your visualization? I know you guys have contrast. Are you using contrast in your transplants? I've used it a couple times, and it's very helpful in the patients with the deep transplants and a lot of sort of swelling around them where you just can't pick up those hepatic arteries. So I've had one patient where I successfully saw the hepatic arteries. They were small, but the waveforms were normal, and the surgeon was reassured, and we saved them a trip down to the CT scanner or down for an angio. So this is an article from Ed Grant's group, and he was at UCLA, I think, at the time. But anyways, they had similar findings. Basically, if you didn't have flow on color Doppler ultrasound, about 3/4 of them actually, they could get flow on contrast enhanced ultrasound, and then they raised basically their specificity and their sensitivity as well. So the ultrasound sensitivity for a thrombosed hepatic artery rose to 1. Okay? And the 2 that had no flow with contrast were confirmed by angio to be occluded. Okay? So does it matter which one is low or how many? The answer is no, it doesn't. So here is the right hepatic artery is low, the main is fine, the left is low, and where was the stenosis? It was actually in the main. Went on to balloon angioplasty, and unfortunately didn't do so well. After angioplasty, it's even worse. Resistive indices are lower, and here you can see it again. Very, very tight stenosis. They placed a stent. So does this protect the patient? Well, again, unfortunately not. You can see that the parenchyma is becoming abnormal with hypoechoic areas centrally, and you can see, again, on CT, very, very infarcted area here and bad biliary necrosis along the porta. You can see it here as well, the shaggy common duct and hepatic ducts, and unfortunately 6 months later. So this is why it's such a disaster for these patients, because you just can't get over it, and this patient basically is living with tubes and stuff draining his liver and less functioning liver as time goes by. What about the outflow side? Less of a problem, but so the cadaveric transplants do pretty well. In the living donors, actually there's more problem because you're trying to anastomose, for example, just the right portal vein onto the regular portal vein or the right hepatic vein onto the cava. So you have a mismatch in size. These patients will present with abdominal pain, ascites, poor liver function. Sounds like Budd-Chiari, right? And on Doppler, we'll diagnose a monophasic waveform in the hepatic veins, and also you can look for a pressure gradient on angio. So here's a patient who has thrombosis of the IVC. You can see here's a clot here. And also, you can see in the middle hepatic vein, it's sort of a monophasic waveform. When it gets closer to the heart here, at the IVC junction, it's got a little bit more pulsatility to it, but you can see the velocity is also elevated here, 176 centimeters per second. So another patient, an old case, this patient had a fairly large clot in the cava, and they'll just put these patients on anticoagulation. They don't go back in after them. Okay. This patient had basically a damped right hepatic vein, middle hepatic vein was fine. This was seen on a couple of occasions. Patient was asymptomatic. They did nothing. So we're not going to do much without symptoms. This patient, unfortunately, did have significant symptoms, and again you can see velocity here at the area of the stenosis, 151. Velocity proximal is only 41, so again about a 3-to-1 ratio. That's a significantly narrowed vein, and this patient actually went on to have an Ivc revision. So, as did this patient. This was a living-related donor, and you can see here the Ivc is distended, sort of like if you'd had a web in Budd-Chiari, and you can see here again it's sort of a little bit ballooned. And you can see why here on this MR, you can see this is a slit. This is all the IVC, that tiny little dot. And it gets bigger and bigger down here. So there is a really tight stenosis in the IVC. And they tried balloon, they tried various things, plastic, and finally the cardiac guys came down from the heart and put in a stent and relieved his symptoms. So he had a lot of years of abdominal pain and leg swelling. Okay, portal vein. Stenosis is common, but it's usually asymptomatic, so don't worry too much about it. Thrombosis is relatively rare. And so just one example, this patient has sort of a long redundant portal vein, and you can see it's completely thrombosed here, no color at all. These are all hepatic artery waveforms you can see here from the spectral tracing. Here's the CT that correlates it, completely thrombosed portal vein. You can see all her collaterals, of course, are still lighting up. Okay. She actually required a retransplant. So what is portal vein stenosis? Well, it's usually, again, at the anastomosis, right? And angiographically, a stenosis is an 8-millimeter gradient, and we look for, again, these numbers. I look more for a ratio of 3-to-1. That's fairly sensitive for stenosis. And the important thing is, if the patient's asymptomatic, you don't treat it. Many of them will resolve over time. So here's a patient, again, velocity here, not high enough, ratio not high enough, even though it looks tight, and this is sort of scary, and it sounds scary if you're in the room scanning. You don't need to do anything with this. Okay. How about this one? Velocity's high, ratio's high. 3 months later, velocity's normal, ratio. So if the patient's asymptomatic, let it go. This patient, however, had an elevated velocity and a big ratio, and you can see here is a very tight stenosis on the grayscale. It's sort of a little like a web that's gone across there. This patient on CT, you can see this portal vein is tightened to like just to a point here. So this patient was symptomatic, and post-stent you can see now normal flow through the main portal vein in the stent, velocity in the stent is fine. Okay. All right, so what happens when the patient doesn't obey the rules? So this patient has no detectable flow in the main portal vein, but the flow in the left portal vein and in the right portal vein is reversed. Have you guys ever seen this? Flow reversals in the portal veins? So this is a weird thing, right? And how does that happen? So is it a technical problem? We just can't get deep enough, low enough frequency? Well, that's possible. But when I get into trouble like this, when something doesn't make sense, I get a CT. And on CT, what's going on here? Well, there's a huge mass of something, and this is all, what, blood, right? So this guy's got a huge hematoma that is compressing this portal vein, again, to a tiny, tiny little slit. And so it's portal vein compression. It's not really portal hypertension. And when they evacuated it, you can see here the portal vein is fine, portal vein is fine, portal vein is fine. So, so I've seen this a few times where these extrahepatic hematomas provide enough compression on the portal vein that there's just no inflow coming into it. And so the patent portion in the liver actually reverses because it's getting fed from the hepatic artery.
Could we not see the hematoma on ultrasound?
You can, if you look hard. So now when I see this kind of a pattern, they often have a lot of gas, you know, and it's just tough to see perihepatic. But when I see this kind of pattern, I'll have the sonographer go back and say, can you use a lower frequency transducer? Can you get in there, try, look for the hematoma? And usually they can find something. So, okay. So this patient has a normal left hepatic artery, a very low resistance in the right hepatic artery, and main hepatic artery is normal. So what could be a cause of a low resistance waveform just on the right side? Hepatic artery stenosis, right, is possible. What else? You find anything? Well, there's this, what's this here? This looks funny, right? So what do you think is going on? Right, great. It's an AV fistula. You can see a very turbulent flow and big distended vessel here. And here it is on CT as well. Arterial phase here, portal vein is lighting up here from this hepatic artery. And there's a little fistula right there. You can see he's already been coiled once. Obviously, it didn't work too well. Okay. Another guy with an AV fistula, lots of coiling. Again, anytime you see a black hole in ultrasound, put on the Doppler. And sure enough, here, the right portal vein, you can see this arterialized flow in it. Main portal vein is normal. Here's the right hepatic artery feeding into the right portal vein. This guy, here's the angio. You can see the hepatic artery. You can see it filling this big fistula. And again, multiple coils from previous attempts to embolize this. Okay. This is sort of an unusual thing. Have you encountered any of these here? Hepatic arterial steal syndromes. It's thought to be a consequence of too much flow coming in from the portal vein. And really, I'll show you the examples. You diagnose it by arteriography. The literature says the patients will have high resistive indices. I have not experienced that, okay? And the treatment is basically to embolize the splenic vein. So here's a patient of ours. This left hepatic artery is a high RI. The main was actually low. So it didn't, again, something that doesn't make sense. Why is it high out here, low here? Right hepatic artery is low. Portal vein had a lot of flow in it. So this patient went on to angiography. And on angio, when you inject, you see here's this little dribble coming into the hepatic artery, and whoa, the splenic artery is just stealing all the blood. So this is splenic artery steal. And you can see here on the venous outflow, again, very enhanced spleen and splenic vein. So you need to embolize, basically, the splenic artery and control it. So post-coiling, you can see the hepatic artery feels a lot better, and the waveforms are now pretty good. And the main hepatic artery wasn't bad to begin with, but the right still looked bad immediately, but within 24 hours it came back up to normal as well. So portal vein steal is a different one. These are these cases are from Indihoro at Einstein in Philadelphia. And in this case, residual varices pull blood from the portal vein. Okay, so the liver is now starved for portal venous flow. Okay. The splenic artery steal is depriving you of hepatic arterial flow. So this patient had poor portal vein flow post-op, and he returned to the OR. You can just, day 1, day 2, just very little flow in the portal vein. And they had revised anastomosis at the portal. They thought that was the problem, and they still couldn't see any flow in this portal vein. This is an intra-op scan, and very little flow. So actually, they went back and looked, and they had very large splenorenal varices that were ligated, and then the portal vein flow actually improves. And just to show you pre-op, this is what this patient looked like. So I think the surgeons are smarter now. A lot of these patients have pre-op CTs, and you know if there are big splenorenal varices or big coronary varices, and the surgeon will ligate those before they put the transplant in. But if somebody forgets or didn't realize it, or for whatever reason couldn't recognize that these collaterals can pull the blood basically out of the portal vein and away from the liver. So here's another patient, same idea. 5 months post-transplant, it presented with a thrombosis, and the reason was you can see these dilated coronary veins here, and you can see this is all the clot in the portal system and the coronary varices. And after they ballooned it, patient did much better, and they reestablished flow. Last couple minutes here, renal pancreas transplant. Basically, we do a few of these. I'm not sure how many you do. The hookup is basically you have to hook up the splenic vein to the iliac, and you have to hook up the arterial supply, which is the SMA, and the splenic artery into the iliac. And you do that basically from a combined trunk. And then, of course, the pancreatic duct has got to empty somewhere. We usually empty it into a roux loop. There have been, in the past, some people used to do it into the bladder as well. Notice that the pancreas is sort of upside down and backwards. In other words, the tail is on the right side instead of the left side, and the head is inferior. Okay. So most common complication for pancreas, basically arteries and both arteries and veins, but venous is probably a little bit more common. And so we pay a special attention to finding patent renal veins. The normal transplant, again, remember the head is going to be over here and the tail is going this way. So we're going to look at the iliac artery, iliac vein. You want to see the portal vein, and you want to see the SMA as well as the splenic artery. Okay. Because the splenic vein is not draining anything, there's no spleen attached, you may not see flow in the distal third of the pancreas. Okay. So again, more normal. Here is a patient, again, splenic vein goes out pretty far here. And you can see the arteries, not necessarily low resistance as they come straight off the aorta. As you get more distal in the pancreas allograft, you can see that the RIs become lower and more like what you would expect in the kidney. And so I just think of this basically as similar to a kidney study. So the big problem is pancreatic vein thrombosis, portal vein thrombosis, and you can see here is a patient who has it, reverse diastolic flow, the same as you would see. So the waveforms are very similar to what you see in the kidney. This patient was initially normal, and then there was no vein on the follow-up study. So in conclusion, Doppler ultrasound is central to the management of renal, hepatic, and pancreatic transplants. We need it for diagnosis of arterial and venous thromboses and stenoses. We have to localize correct areas for biopsy, and it also identifies post-interventional sequela, including AV fistula and pseudoaneurysms. And with that, I want to say thank you. This is my town by the river. This is the U of R Medical Center. That's Rochester down there, and that's the Genesee. So thank you very much for your attention. Okay, any questions? Yes.
Hi. This is regarding hepatic artery.
Okay.
Is there any changes that you have seen in your ultrasounds, post-op number 0 or post-op day number 1, regarding the quality of the organ? Because nowadays we transplant organs with
extended criteria.
Right? So
Yeah, yeah.
Or a lot of prolonged cold ischemia time. So I expect these organs to have probably more, is there
More parenchymal problem. The patients that have the high resistive indices, the RI of 1, more often, those are usually the extended criteria donors, the extended warm ischemia time, older aged patients, et cetera, et cetera. That would be the only thing that I could say that I could distinguish. We don't really, it's hard to assess volume flow right now. If that would be, I think that's more useful in kidneys than it is in liver. And there's so much going on as the liver is readjusting, the amount of portal blood it's getting, the amount of hepatic arterial blood it's getting from its new donor, that I don't know how much we can say in the first 24, 48 hours. So.
In your center,
Mm-hmm.
you were saying if you don't see hepatic artery flow, that doesn't mean that there's no hepatic artery flow, but you will follow the patient. And
We'll go back 6, 7 hours.
Doing CT angio, because we know if there's hepatic artery thrombosis, then the quality of the organ, and then the longer we wait.
Right. We can. It's just most of the time we can see it. There's a very small number of patients where we see nothing. Maybe 1 or 2 in 6 months where you really see nothing. Usually what happens is we'll see arteries, we might see the right and the left and not see the main, or sometimes we'll see main and right and can't see left, and so we'll keep going back until we can see that. So yes, you could do CTA. Our intensive care unit's on the 8th floor, our CT scanner is on the ground floor, and so the patients have got to come with the full court press, and they're people bagging them and everything down to CT. So often also these patients may have renal insufficiency as well. So they may or may not be able to have a lot of IV contrast. If you really need it, you would give it to them. But I think I would rather use ultrasound contrast. And so that's actually what we have done in the last couple of patients. And one patient, we were all set to go up and give him ultrasound contrast, and they'd scan him at 7 in the morning, and there was just still no flow that they could see. And I got there at noon and put the transducer on. It was wide open. So, so I lost my chance. But for us, it's, yeah.
The contrast ultrasound is
I believe that it does work very well. You have to know that you're looking at the hepatic artery, and you have to look early, because a lot of these patients, the portal flow is just so huge that it sort of drowns out the hepatic artery signal until they sort of readjust. So, okay. Other questions?
I had a question, Deborah. How important is it to have information about the mechanics of the transplant that's just been done? Because there's so many variations, as you've alluded to.
Well, the renals, I think it's probably even more important, because often there are multiple renal arteries. And if you don't know that there are multiple renal anastomoses, you don't go looking for them.
Yeah,
So, so you may not see them, especially if you're looking for stenosis or whatever. For the livers, they pretty much hook them up the same way. The place where we get in trouble is when they've had a problem, and it's usually with the arterial anastomosis, and they performed a jump graft or something else, and then you're going off and trying to look out in the mesentery for something, or up higher. When you're trying to look for things out of the normal position, that's difficult, and you really can't do that without help from them. Usually they're pretty good. They'll say on the thing, you know, patient had a jump graft, or patient had a dissection with a revision or something.
So you have an idea what's
Yeah, and we have an electronic medical record, so you can go and look if they've got the report in there yet.
The OR note won't be there yet.
Yeah, well, they're pretty good, but it's not finalized, so it doesn't have a drawing. That would be nice.
Don't you usually get the surgeons to draw us about
That's nice. Yeah, yeah.
I'm just wondering how many of your radiologists actually are involved with giving ultrasound contrast?
Right now, it's me.
Just you?
It's pretty much me. There were a couple of guys in interventional radiology who were interested. One of them, unfortunately, who was very interested, unfortunately passed away last year. So, so I'm the one who's the most interested. I did some clinical trials long ago, so I'm comfortable with ultrasound contrast. The stenographers are actually reasonably comfortable at this point too. There are 3 or 4 of them who can run the machine and, you know, get the settings right and turn it dark for you and stuff. So,
But you're always in the room, and it's just you.
yeah. So it's not an everyday thing. Someday it will be. When it's approved, it will be. So I have several partners. I'm sure they'd be happy to learn, but they're not going to learn something that they're going to do once every 6 months or once a year. It's not practical. So for now, we're sort of not in a perfect place. But do you guys use?
Same.
Yeah, same. Yeah. Yeah, it's hard to get geared up for something you're going to just use occasionally. I'd say if you want to use contrast, I'd do it starting with renal lesions in patients who can't have IV contrast for low creatinines, because they're a huge population, and you're providing a service that you can't do with CT or MR. And then everybody gets comfortable looking at little vessels and getting spectra and things and how things look. And you can sneak a look at the liver at the same time. So, okay, yeah.
I have a question about, sometimes on call, for example, we do a kidney or a liver post-op day 0 a couple hours later. And when things are pretty straightforward, there's a kink or there's a stenosis, you know what to do with it. The problem is when you have, like the case I showed you today, you have an abnormal Doppler, you can't explain it, you've looked at extrinsic compression, intrinsic, and then what do you do? I mean,
Then,
where's the comfort zone where you say, this we can wait and repeat the ultrasound 6 hours later?
Yeah.
Or they have to go
When
back.
it's something brand new that you've never seen before, my experience has been that you have to let them go on clinical, and if the patient's not making urine or whatever, then the kidneys they got to go back to the OR to try to salvage whatever it is that's wrong. And in your patient's case, it was some funny, who knows, compartment syndrome, or maybe there was nothing wrong at all, and that renal vein would have gotten better with time on its own. You just never know, because they can change so fast, just in a few hours. So, but I think the incision's already there, and the price to pay if you lose it is huge. So our surgeons are happy to go back, and if they go back and it all looks fine, and I was wrong, you know, they take the responsibility for that. They're pretty, you know, we talk a lot, and I say it bothers me, and they say, okay, we'll go take another look.
So you have a low threshold.
Low threshold for going back. So now that has to be balanced against New York State reportable incidents, which, because if you take somebody back for no good reason, you know, but they can decide, you know, if they really want to, they can get an arteriogram and see what's going on too. And if the arteriogram looked fine, they could stay out of the OR. But they're probably more likely to get a CTA actually than a perk. All right, you guys are all hot, tired. It's been a long day listening to me, eight hours. So,
Well, thank you very much for this very excellent and practical talk. And
thank you.
Also, thanks for spending all this time with the residents. All the cases were fantastic and with good teaching points. So
good. Well, thank you so much.
Thank you.
Oh, thank you.